Hello everyone, this is Dr. Sangeeta Chaudhary. I'm a consultant physician. I welcome everyone to this live session. I hope you will really enjoy the classes. I'm going to talk about coronary artery disease today. Basically, I'm going to give you a series of lecture on internal medicine. These lectures will be very much beneficial for your examination purpose, and it will be very much beneficial for your clinical practice as well. So I hope that you will listen to my classes. Please watch the video till the end and kindly share the video. So today I'm going to discuss about one of the very important topic, that is coronary artery disease. I'm going to start with the cardiovascular system, as I say. So coronary vascular disease. So coronary vascular disease, it is also known as ischemic heart disease or myocardial infarction, and in general terminology, all of us, we know it as heart attack. So ischemic heart disease or coronary artery disease is the most common cause of death worldwide, and it causes the highest economic burden on the health sector. So it is very important for us that we know how to diagnose, manage a case of coronary artery disease so that we can save a number of lives. Coronary artery disease, actually it is not a single disease, but it is a spectrum of diseases. It includes obstructive coronary artery disease, which I'm going to talk about. It also includes many of the non-obstructive causes of coronary artery disease. So among the obstructive coronary artery disease, the commonest cause being the atherosclerosis of the coronary artery, which is commonly known as ischemic heart disease. So in the coronary artery disease, that is the obstructive type, we have stable angina, we have unstable angina, we have non-ST elevated MI, and we have elevated MI. So in today's lecture, I am basically going to discuss about stable angina. So let's know about stable angina, which is one of the spectrum of the coronary artery disease. So before going to the disease proper, I would just like to talk a little bit about the coronary circulation. Okay, so coronary artery, we already have learned in the anatomy about coronary arteries. It will just be a quick revision about the coronaries before we begin with the disease proper. So coronary arteries are two in number. They are epicardial coronary artery. Why epicardial? Because they lie in the epicardial connector. They are right and left coronary artery. So right coronary artery, this is the right coronary, okay? The right coronary artery, it arises from the anterior aortic sinus. Both the coronary arises from just above the ascending aorta from the aortic sinus. So the right coronary arises from the anterior aortic sinus, and then it runs in between the right auricle and the pulmonary conus or pulmonary. Then it descends almost vertically, okay? Almost vertically anterior atrioventricular groove, and while descending in the anterior atrioventricular groove, it gives off many branches. These are the small branches we can see. These are the ventricular branches, and as we can see, they supply the anterior part of the right ventricle. One of the branch of the right coronary artery, which is the largest branch, ventricular branch, that is the right marginal artery. Right marginal artery, as we can see, it runs along the lower border of the heart. This right coronary artery, it winds posteriorly and it continues into the posterior atrioventricular groove like this. Then it descends into the posterior interventricular groove just to get anastomosed with the branch of the left coronary artery. This is the branch of left coronary artery. Right coronary artery ends here, just near the apex in the posterior interventricular groove. There are atrial branches also from the right coronary, which supplies the part of the right atria and little bit of the posterior surface of the right and left atria. And importantly, it gives off some branches to the conductive system of the heart. It gives off branch to the SA node. Okay, it gives off branch to the AV node. Okay. Now talking about the left coronary artery. The left coronary artery arises from left posterior aortic sinus, just above the aortic valve. and then it runs in between the left auricle and the pulmonary conus. Then it runs in the atrioventricular groove. This is the atrioventricular groove, and in this groove it gets divided into the left anterior descending artery. This is the left anterior descending artery, which runs in the anterior interventricular groove. As the name suggests, it is in ventricle, interventricular groove. Okay, so this is one of the branches of left coronary artery, and the other branch is the circumflex. Okay, so this is the circumflex artery. Now, while descending into the anterior interventricular groove, the left anterior descending gives off many branches, okay, to the anterior surface of the left ventricle. And after giving these branches, it winds posteriorly into the posterior interventricular groove to get anastomose with the right coronary artery. And the circumflex branch, it is also a big branch. It runs laterally and then it winds backwards. It goes backwards into the posterior atrioventricular groove, and ultimately it also gets anastomosed with the branches from the right coronary artery. So this is in short about coronary circulation. Okay, this is the posterior aspect. I have already described about the posterior aspect. Now, if we take a cut section of the heart, okay, here if we take a cut section of the heart and if we look from inferior aspect, then we can see that the light color is the supply by the left coronary artery, and the orange color, okay, it is the blood supply by the right coronary artery. So we can see that majority of the part of the left ventricle and part of the right ventricle, as well as most of the part of the septum, anterior portion of the septum, is supplied by the left coronary, whereas right coronary mainly supplies the lateral aspect of the right ventricle, that is the free wall of the right ventricle, and it also supplies the inferior aspect or the diaphragmatic surface of the heart. So this is about the blood supply of the heart in short. Now a little bit about the physiology of the coronary circulation. The epicardial coronary artery, just now I have described. Epicardial coronary artery are also known as microcirculation. Okay? Their diameter is more than 400 micrometer, and this epicardial coronary artery, it gets continued as pre-arteriolar or pre-arteriolar small branches less than 400 micrometer. Then it gets divided into arterioles, and arterioles gets divided into capillaries. So the coronary circulation, which is epicardial coronary artery, if the diameter of the coronary arteries are more than 400 micron, till that limit it is microcirculation. And when it goes below 400 micrometer in diameter, it is known as the microcirculation. Okay, we're going to talk about basically the macrocirculation, that is the epicardial coronary arteries and artery disease. But just to tell you that there is also something known as microvascular angina. Microvascular angina means when the smaller arterioles or pre-arteriolar coronaries are involved, that is less than 400 micrometer diameter. If we talk about the main stimulus for vasomotion or blood flow in the epicardial coronary artery, it is the flow. In the small arteries, it is the pressure. In the arterioles, it is the metabolite, and in the capillaries, okay, also it is the metabolite. The main function of the epicardial coronary artery is the transport, and in the microcirculation, it is the regulation of circulation. It's very important. The pre-arterioles and in the arterioles, they are mainly responsible for the regulation of arterial circulation, and they are responsible for almost 75% of the coronary resistance. That means resistance offered by the arteries to the blood flow. And in the capillaries, they are mainly responsible for exchange of oxygen, exchange of metabolites. If we talk about, as I have already mentioned, if we talk about the percentage of total resistance of flow, it is the maximum in this area. Okay, it is the maximum in the smaller pre-arterioles and the arterioles. So just to mention you that in a normal heart, whenever the demand increases, that means whenever the oxygen demand increases, these resistance vessel, they get dilated. Because of the dilatation, the resistance decreases and then the coronary blood flow increases. Okay, so whenever there is an increased demand, the blood supply also increases in a normal heart. I'm talking about a normal heart. Okay, so this is the normal physiology. Coming to the ischemic heart disease or coronary artery. What happens in the ischemic heart disease or coronary artery disease? Basically, there is an inadequate blood supply and oxygen supply to a portion of the myocardium. Imbalance between the myocardial oxygen supply and demand, as I have mentioned, and the most common cause of this imbalance is the atherosclerotic disease of the epicardial coronary artery. That is the bigger coronary arteries where the diameter is more than 400 micrometers. That is the most common cause of coronary artery disease. Other than this, there are few other causes of coronary artery disease as well. As I have said, there are non-obstructive causes as well. Like atherosclerosis is the non-obstructive cause, and among the obstructive cause, we have thrombi formation in the coronary artery itself. Rarely, embolism can cause obstruction in the coronaries. Coronary vasospasm may lead to angina, which is also known as Prince metal angina. I'm going to talk about this Prince metal angina. Okay. And sometimes there is congenital abnormality of the coronary arteries, which also may lead to. For example, if the left coronary artery, instead of arising from the aortic sinus, if it arises from the pulmonary artery, then there will be high chance of development of ischemic heart disease. So congenital abnormality is also one of the cause. Coronary arterial dissection, it is a rare cause, of course. In the coronary arterial dissection, there is the coronary arteries walls, they get split, okay, resulting in reduced blood flow to the heart. Ischemic heart disease, it is a spectrum of disease, as I said. It includes stable angina, which is secondary to chronic coronary artery disease. Not an acute, really, it is chronic coronary artery disease. The other one is acute coronary syndrome. So what is acute coronary syndrome? Acute coronary syndrome, it is compatible with myocardial ischemia and or infarction that is usually due to an abrupt reduction in the coronary. Okay, the important word is abrupt. It is an acute condition where there will be abrupt reduction in the coronary flow, and it includes unstable angina, okay, unstable angina and NSTMI. NSTMI stands for non-ST elevated myocardial infarction. Unstable angina and NSTMI together known as NST-ACS. Okay? Non-ST elevated acute coronary syndrome. Okay, and the other one is STEMI, STEMI, means ST elevated myocardial infarction. These includes acute coronary syndrome. So in today's lecture, I'm going to concentrate more on stable angina, and I'm going to talk about the acute syndromes in my upcoming lectures. A little bit about the pathophysiology of ischemic heart disease. We know that the arterial wall has three layers. It is adventitia, media, and intima. Okay, and this is the lumen. This is just a diagrammatic representation of the pathophysiology. So the lumen, and whenever there is coronary atherosclerosis, there will be formation of plaque. Usually the plaques are formed in the wall, okay, and later on this plaque encroaches the lumen. Okay, so this is a fixed plaque, we can see atherosclerotic plaque, and a fixed stable atherosclerotic plaque give rise to stable angina. Why stable angina? Because stable angina usually occurs, not usually, most of the time it occurs after a certain amount of exertion or after a certain amount of emotional stress. And if the patient takes rest or the patient takes nitroglycerin as medication, then the patient gets completely relieved. That is the stable angina. If we talk about the acute coronary syndrome, what happens in the acute coronary syndrome? The stable plaque, which was there in case of stable angina, certain reason it gets disrupted. And after the disruption of the plaque, we all know that there will be, the platelets will come into action. There will be activation of platelets and aggregation of platelets, and coagulation cascade will come into action, and then there will be ultimately formation of a thrombus. Okay, so whenever there is plaque disruption and platelet aggregation, it results in unstable angina. And then if there is formation of a thrombus, but which is not occluding the whole of the lumen, it is occluding a partial lumen occlusion is there, it will cause non-ST elevated MI. And if there is mural thrombus, okay, means there is complete occlusion of the lumen, then it will cause what is known as ST segment elevated myocardial infarction. So let's talk about the risk factors. It is very important that we know about the risk factors of myocardial infarction or risk factors of ischemic heart disease. The risk factors can be modifiable risk factors or it can be non-modifiable risk. As the name suggests, modifiable means somewhat modify the risk factors or we can control them. But non-modifiable risk factors, we cannot actually do anything for them. Okay? So these are certain modifiable risk factors, for example, smoking, okay? Diabetes mellitus, dyslipidemia, okay? Hypertension, obesity, okay? All these things, they actually accelerate the process of atherosclerosis. That is why these are the risk factors of development of coronary. Physical activity, again, a modifiable risk factor. Cocaine abuse, cocaine or amphetamine abuse, high dose of cocaine and amphetamine again cause ischemic heart disease. And talking about the non-modifiable risk factors, so age, increasing age itself is a risk factor for ischemic heart disease. Okay, male sex, male are more prone to develop ischemic heart disease. Talk about the statistics, it is seen that almost 70% of the cases of ischemic heart disease occurs in males, 30% in females. Family history, it is a very important risk factor, non-modifiable risk factor. We need to, while asking the history, we need to talk about the positive family history of premature coronary artery disease or premature heart disease. What do we mean by premature heart disease? If there is ischemic heart disease in a first degree relative male below the age of 55 years, this is for male, first degree relative male, and for female if it is below 65 years. So if in a first degree relative there is a history of premature coronary artery disease, then the person in question will definitely have increased risk for coronary artery disease. Ethnicity, again important. Certain races are more prone to develop coronary artery disease. For example, whites, for example, black males, they are much prone to develop coronary artery disease. These are about the risk factors. Very importantly, we should know about the risk factors, because if we can modify the risk factors, we can modify the future events, okay, future cardiac events. We can reduce the number of deaths. What do we mean by stable angina, or what are the typical clinical manifestations of stable angina? Till now, we have talked about the coronary circulation, the physiology of coronary. We have talked about the spectrum of coronary artery disease. Yep. We have talked about the risk factors. Now, coming to the disease proper. So, how the patient will present to you with stable angina? Patient will have deep, poorly localized chest or arm discomfort, which is reproducible. Okay, it can be precipitated by physical exertion or stress, emotional stress. By physical exertion, we usually mean uh, exercise, hurrying, or having sexual intercourse. These are the examples of physical exertion I'm giving. By emotional stress, we mean if the patient is having extreme fear or extreme anger or extreme frustration, those periods also may lead to development of stable angina. Typically, the pain, the chest pain or chest discomfort lasts for 2 to 5 minutes, not more than 5 minutes. Some book will say 1 to 5 minutes, authors will say it is 2 to 5 minutes. And very typically, as I have already mentioned, it is relieved by rest. There is complete resolution with rest and sublingual nitroglycerin or sublingual nitroglycerin. Not relieved by complete rest, or if it is not relieved by sublingual nitroglycerin, we should definitely review our diagnosis of stable angina and we need for other diseases. So this point is very important. So typically a male patient of more than 50 years or a woman of 60 years, they usually present with chest discomfort, heaviness, pressure in the chest, squeezing kind of feeling in the chest, or smothering or choking. These are the words patients they usually use. Okay? Constrictive pain or feeling of suffocation, smothering, choking feeling, heaviness in the chest. These will be their complaints. Okay? There is something known as Levine sign. What is Levine sign? When you ask the patient whether the patient can localize or pinpoint the area of discomfort or not, patient will not be able to exactly pinpoint, but the patient will keep a clenched fist over the center of the sternum. Pain is usually retrosternal. Most of the time it is patient will clench fist over the center of the sternum, but they cannot just pinpoint. Okay? That is known as the Levine's sign. The nature of the clinical manifestation, it is crescendo decrescendo. By crescendo decrescendo, we mean that the pain or chest discomfort, it increases up to a peak and then it decreases. That is the crescendo decrescendo pattern. So it increases, reaches a peak and then it decreases. Okay? Typically, as I said, lasts for 2 to 5 minutes. Importantly, talking about radiation, usually the pain of angina, it radiates or it can radiate to either shoulder or it can radiate to either a side of the upper limb. Okay, but mainly it gets radiated into the ulnar border of the forearm and the hand. Sometimes patient will also complain of a feeling of tingling and numbness in the fingers. So your patient will come to you with a typical type of squeezing and constrictive type of chest pain, okay, along with the radiation of the pain along the ulnar border of the forearm and the hand. And sometimes it may even get radiated into the back, the upper back, or into the interscapular region. It can radiate into the jaw. Okay? It can radiate into the root of the neck. Okay, it can radiate into the teeth and epigastrium as well. But just to remember, just to mention that it rarely gets radiated below the umbilicus and above the mandible. Okay? If it gets radiated above the mandible or below the umbilicus, then again review our diagnosis: ischemic heart disease or angina. One more important thing is that the pain of angina, it never gets radiated into the trapezius muscle. If there is radiation in the trapezius muscle, it goes more in favor of pericarditis, of ischemic heart disease. There is something known as nocturnal angina. Yes, the name suggests nocturnal angina. Nocturnal angina means patient, they do have angina at night time when they go into sleep. Okay, when they go into bed, they attain the recumbent position. They have chest discomfort and chest pain. That is known as the nocturnal angina. Why the angina happens at night? It is because of maybe two reasons may be there. One, maybe there is episodic tachycardia. Second, maybe there is reduced oxygenation when someone goes into sleep because the respiratory center gets little depressed and there is reduced amount of oxygenation. That may be one of the reason of nocturnal angina. The other important reason is that when someone attains recumbent position, there will be increase in intrathoracic blood volume. When there is increase in intrathoracic blood volume, there will be increase return to the heart. So the end diastolic volume of the ventricle will be more. Okay? More end diastolic volume, more stretch to the myocardium, more oxygen demand. So this will cause nocturnal angina. That is also very important. someone comes to you with a typical complaint of chest pain or angina discomfort only at night, then we need to think of it as a case of nocturnal angina and we need to evaluate the patient. Now, when we take history, other than all the typical clinical symptoms, we ask about the risk factors as well. As I have mentioned, there will be multiple presence of multiple risk factor in patient, and we need to inquire about other atherosclerotic diseases, because whenever there is atherosclerosis in the coronary artery, it means that only the coronary arteries gets affected by atherosclerosis. The other vascular bed also gets affected. Ask in the history about symptoms of peripheral vascular disease. We need to ask about any transient ischemic attacks in the patient because of involvement of cerebral vessels. Okay. These are the questions we need to ask for. And when we examine a patient, we'll be looking to the signs of atherosclerosis as well. Okay. For signs of atherosclerosis, I mean, if there is atherosclerosis in the carotid, then there will be carotid bruit on auscultation. If there is abdominal aortic aneurysm, then again we'll have bruit or murmur on auscultation, aorta, abdominal aorta. And if there is peripheral vascular disease due to atherosclerosis, the peripheral pulses will get diminished. So these are also very important point to look for atherosclerosis in other vascular beds as well. Okay. And if we examine a patient, most of the time, typically on examination, there is no sign. Most of the time, there is no sign on examination. Everything looks normal on examination of the cardiovascular system. But sometimes there may be transient third and fourth heart sound. Okay, we'll be able to hear transient heart sound. And on examination, there may be a dyskinetic cardiac effects. There may be transient mitral regurgitation because of involvement of the papillary muscle. There is an infarction in the papillary, and then there will be features of mitral regurgitation, that is the development of systolic murmur in the apical area or mitral area. Even sometimes in severe cases, patient may have pulmonary edema, frank pulmonary. Will get signs of physical signs of pulmonary edema. So these are the few signs we may get. But again, I said on examination, the patient may be normal on examination of the cardiovascular system. Coming to the investigations. Okay? So we talk about the investigation. The first investigation usually do is ECG, electrocardiogram, and it is also known as EKG or EKG, we can say EKG. May be normal. Most of the time it is normal. Okay? And if the patient had previous MI, then there will be signs of old MI in the ECG. For example, there will be presence of pathological Q wave in the ECG in particular leads. Okay, that is one of the sign of old MI may be present if the patient had previously ischemic heart disease. And there may be dynamic changes. Transient dynamic changes, for example, there may be transient STT changes. So elevation of the STT segment may be there. Transient, that means only during the episode there is changes, and as soon as the episode subsides, the ECG also subsides. That is very typical and very important. Okay, and that is kind of diagnostic, because when the patient is having chest pain, you do an ECG, you find the changes in the STT segments, you find it, and as soon as the patient gets relieved of the chest pain, the symptoms subsides. That is very, very important. Otherwise, there may be in the ECG, there may be signs of rhythm disturbances or LVH. So these are not very diagnostic. So this is important. Transient dynamic change. Stress testing. One of the very, very important tests we do to diagnose a case of ischemic heart disease. Stress testing, we usually do electrocardiogram, ECG, We ask the patient to exercise on a treadmill. There is a standardized incremental external workload given to the patient, the treadmill test. This stress testing is also popularly known as treadmill test. We all know it as treadmill test, exercise stress testing. So there will be an incremental increase the external workload through or following the Bruce protocol. Following the Bruce protocol, okay, and the patient has to, patient has to jog in the treadmill, and the blood pressure of the patient, heart rate, and ECG will be recorded before the patient starts exercising, during the exercise period, and also after the exercise. Okay? And then we're going to see if there is any changes in the ECG, okay, which is specific for ischemic heart disease during the stress test or even during at the time of recovery. Okay. So suppose if there is a positive result, I'll tell you how we say it is positive or negative. Suppose there is a positive result in treadmill test or exercise stress test for a 50-year male. This is just an example, okay? For a 50-year male who presented with typical angina pectoris and his stress test has come positive, that means he had almost 98% likelihood of having severe coronary artery disease. Such important the test is. This test actually has a sensitivity of 75%. Sensitivity of 75%. If the test is negative, we cannot actually exclude the ischemic heart disease. But if the test is negative, we are almost sure that the patient does not have stenosis of the main left coronary artery, left main branch, or there is no triple vessel disease. That is the main idea. Procedure. I have said about the procedure. The patient's blood pressure, heart rate, and ECG will be monitored before, during, and after the procedure, and we will see changes in the ECG and blood pressure. What is the ischemic response when we say the test is positive? If there is ST flattening, if there is ST flattening or down sloping ST segment, not up sloping. Remember that, down sloping ST depression, okay, of 1 mm, and the duration of it is 0.08 second or more. If these two criteria are fulfilled, then we call that test as positive treadmill test or positive stress test. And then the patient has very much likelihood of having coronary artery disease. That is the ischemic response. That means when we say the test is positive. Okay. When to stop the test? There are certain criteria when we stop doing the test. For example, if the patient develops chest discomfort, chest pain, or any anginal equivalent, for example, dyspnea, or patient develops palpitation, if patient develops fatigue, these are all anginal equivalents. If patient develops this thing, or if the patient achieves 85% of the predicted maximum heart rate, or if there is ischemic change in the ECG, then we are going to stop doing the tests then and there. Okay, and we will observe the patient in the recovery period. For the treadmill test, we need to know the contraindications as well. What are the contraindications? Because for each and everyone presenting with chest pain, we cannot ask the patient to go for a treadmill test. There are contraindications. The patient had anginal pain within last 48 hours. If the patient has arrhythmias going on, if the patient has uncontrolled heart failure, or if the patient has acute myocarditis. In these cases, even in case of severe pulmonary hypertension, don't ask the patient to go for a treadmill test. Contraindication will be like anginal pain in last 48 hours, general pain, last 48 hours, heart failure, which is uncontrolled arrhythmias, severe pulmonary arterial hypertension, okay, or acute myocarditis. These are few contraindication of doing a treadmill test. That also we need to know about. Cardiac imaging. Many times we need to depend on cardiac imaging because for many patients not be able to do a treadmill test or exercise stress test. Suppose for example, if the patient has all these contraindications, exercise stress test, or if the patient is obese who cannot do exercise, these conditions will not pose the patient to a treadmill test, then we need to do cardiac imaging with pharmacological stress. As the name suggests, pharmacological. Pharmacological means with use of certain drugs, we need to do the cardiac imaging test. So what are the drugs we use for pharmacological stress testing? We use dipyridamole or adenosine. What do? They will do a coronary steal. What do you mean by coronary steal? Actually, when we give dipyridamole or intravenous adenosine, they will divert the coronary supply from the diseased area to the non-diseased area. Okay? And then we will see whether the patient develops signs of ischemia or not. That is the coronary steal. Or we can use incremental infusion of dobutamine. And is one gynotrop we know. So if we give incremental doses of dobutamine, will increase the myocardial oxygen demand. Again, we will see if the supply is adequate enough to fulfill the demand or not, or if the patient develops ischemia. So we will use these medicines, okay, either dipyridamole or adenosine or dobutamine infusion we will use, and then we will do cardiac imaging. So this is an echocardiogram image, okay, pharmacological stress testing and doing an echocardiogram. This picture is taken from the Harrison's Internal Medicine, the latest edition. This is at rest. Okay? This picture taken at rest, and this is the left ventricle. Okay? This is LV. And this picture is taken during stress, okay? Pharmacological stress. This is again the LV. Okay. So if you compare these two, images, you can see that the diameter of LV has increased the stress test. Okay? And there was as it is not a motion video, I cannot show it to you, but there was finding of dyskinesia in the apical area. Dyskinesia means reduced movement. So this stress echo was done in a 45-year male who was otherwise very fit but had typical of angina, and the stress echo was done. Then it was found that there is ischemic changes in stress. For example, there is dilatation of the LV cavity, and also there is dyskinesia in the apical segment, the left ventricle. Next, coronary arteriography or coronary angiography. We all have heard about coronary angiography, but it is not that for every patient we will, we will ask the patient to go for a coronary angiography. There are indications of. For example, if the patient is severely symptomatic even after the medical treatment, medical therapy, and the patient is considered for revascularization, in those cases, we will go ahead with a coronary. If there is diagnostic difficulties, means with the help of other imaging techniques, diagnose a patient, there is diagnosing difficulty, then we will do a coronary. Someone who has survived a cardiac arrest, we will do a angio. With ventricular dysfunction, someone who has ventricular dysfunction clinically, will go ahead and do a coronary angio. And those who are at high risk of sustaining future coronary events, a coronary angiogram, and we will see if the or if it can undergo revascularization. These are the important indications of doing a coronary angiography. Okay. So what we will see by doing a coronary angiography, we will find out the amount of stenosis in a particular segment of the coronary, and if it fills the criteria for revascularization, or revascularization, either in the form of percutaneous coronary intervention, or in the form of AB coronary artery bypass graft. Coronary artery bypass graft. We know about this, we have heard about it. CT angio and cardiac MR angio can also be done. These are non-invasive alternatives for a invasive coronary arteriography. Radiation exposure is there in CT, of course. That is the disadvantage of CT scan. There will be radiation exposure. And what will be the disadvantage of MRI? It is very much difficult to do MRI in a moving, in a moving heart. Okay, so difficult to do in a moving heart. Otherwise, CT angiography and cardiac MR angiography, cardiac magnetic resonance angiography can be done as a non-invasive alternative of diagnostic. Lab test. The investigations till now I was discussing, that is ECG, then stress ECG or treadmill test, or pharmacologic stress with cardiac imaging, that is two-dimensional echocardiography, or coronary arteriography and coronary CT or MRI arteriography. These are mainly for the confirmation of our diagnosis. Now we need to do certain lab tests also to identify if the patient has risk factors for the development of coronary artery disease. Because we need to take care not only of the disease per se, but of the risk factors as well. So we will do this lab test. We will do blood glucose estimation to find out if the patient has diabetes. Diabetes accelerates the atherosclerotic process. Urine examination we will do. We will see presence of sugar in the urine or not, or if there is albuminuria in the urine or not. We will do a serum lipid profile to see if there is any dyslipidemia or not. We will do a serum creatinine. Okay. We will do thyroid function test as well, because hyperthyroidism, ischemia of the myocardium. There is something known as HSCRP. HS means high sensitivity. High sensitivity. If high sensitivity C-reactive protein HSCRP elevated and its level is 1 to 3 milligram per liter, then it gives a high likelihood of CAD in the particular patient. So this we can do, okay, to find out if there is high likelihood of development of heart disease or coronary artery disease in a particular patient or not. It is helpful for treatment monitoring also. Chest X-ray. We need to definitely do a chest X-ray. Chest X-ray gives us many information. From the chest X-ray, we will know if there is any cardiomegaly or not. We can know if there is any cardiomegaly. We can find out if there is any signs of heart failure. If there is ventricular aneurysm. These are the important information. Or if there is signs of pulmonary arterial hypertension also. So simple chest X-ray will give us all this information. Signs of cardiomegaly, signs of heart failure, signs of arterial hypertension, or signs of ventricular aneurysm can be identified from a chest X-ray. This is all about the investigation. So here is the protocol of evaluation of a patient with suspected ischemic heart disease. Okay, that means the patient has presented to you with all the typical clinical manifestations of ischemic heart disease. Now, how you proceed with the investigation? What is the protocol? You need to do stress testing when? If the diagnosis of ischemic heart disease is uncertain, to assess the functional capacity of the patient, to assess adequacy of treatment program for ischemic heart disease, and if there is markedly abnormal calcium score on electron beam CT. Now, what is this? What is the fourth point? Why it is important to know the calcium score of the coronary artery? It is because the atherosclerotic plaque, it undergoes calcification over a period of time. And if we can quantify the calcium content in the coronary artery, we will be able to know the extent of atherosclerosis in the coronary artery. And it can be done with the help of EBCT, electron beam CT scan. And for quantifying the amount of calcium in the coronary, there is a score which is known as Agatston score. Agatston. This will be important for the MCQ or competitive exam purpose. So Agatston score is the score with the help of which we know or we quantify the calcium content in the coronary arteries. So if the patient has one or the other of these criteria, then we need to see if the patient can exercise adequately or not, or if there is any contraindication for exercise for the patient or not. If the patient can exercise adequately, okay, then we will subject the patient for treadmill test. Okay? And if the patient can exercise adequately and if there is no confounding features on ECG, resting ECG, no confounding feature on resting ECG, the patient exercise adequately, then we will subject the patient for treadmill test, and depending on the results of treadmill test, we will decide what to be done next. If the patient cannot exercise or if there is confounding features in the resting ECG, then we cannot subject the patient for exercise stress test. In these cases, imaging is necessary. Okay? So we will perform imaging like as I have already mentioned. Two-dimensional echo can be done. A normal two-dimensional echo also can be done, and with stress echo, that is with pharmacological stress also, 2D echo can be done. Better idea. Perfusion scan can be done. Nuclear perfusion scan. MIBI, methoxy isobutyl isonitrate. MIBI, methoxy isobutyl isonitrate. Okay, this is the name of the compound. Okay, so nuclear perfusion scan is done. Cardiac magnetic resonance imaging. Okay, cardiac MR scan, CMR can be done. Okay, and cardiac PET scan, positron emission tomography. Positron emission tomography. So this can also be done. So these are the imaging. Two-dimensional echo can be done. Nuclear perfusion imaging can be done. Then cardiac MR scan can be done, and this cardiac PET scan. These are the scans can be done in a patient of suspected ischemic heart disease when the diagnosis. So this is basically the protocol for evaluating a patient with ischemic heart disease. Coming to the most important and the last part, that is the management of stable angina. How do I manage a case? If we can manage a case of stable angina, we will really be able to prevent future cardiac events and future death, which is very, very important. So first of all, reassurance to the patient. Reassurance and health education, patient and patient, very, very important. we need to reassure the patient that with stable angina, the patient have a prolonged and productive life and a good quality of life. If necessary, we can give examples of different clinical trials where the patient has been found to be having a prolonged and good quality life. So this is important. Reassure the patient that you'll have a good quality prolonged life if you follow the medications, follow the lifestyle. Next thing, what we do, we need to identify and treat the aggravating factor for development. So what are the aggravating factors? Obesity, hypertension, hypothyroidism, anemia. Anemia, very importantly, anemia is quite common in Indian population, and anemia will reduce the oxygen carrying capacity of blood. This way, anemia aggravate the ischemic heart disease by reducing the supply of oxygen to the myocardium. Pulmonary diseases, because of various pulmonary diseases, there will be less oxygenation of blood. Because of less oxygenation of the blood, again the oxygen supply to the myocardium will be compromised, which will aggravate the stable angina. Left ventricular hypertrophy, again left ventricular hypertrophy has increased demand for oxygen and blood supply. Again, it can aggravate aortic stenosis. Again, it is important aggravating factor for ischemic heart disease. HOCM, hypertrophic obstructive cardiomyopathy. Hypertrophic obstructive cardiomyopathy. I will talk about all these diseases in detail in my upcoming lectures. For now, just know that these are the aggravating factor for coronary artery disease, and we need to find out this aggravating factor and control or treat this aggravating factor if we manage it. First reassure, then find out the aggravating factor and the condition. Adaptation of activity is very important, as we have seen that stable angina is usually precipitated with physical exertion. Okay, so it is very important that the patient does some adaptation or limitation of the physical activity. The energy requirements should be reduced in morning time, cold weather, or after having a meal, because uh, these are the timings when they are more prone to develop ischemic heart disease or stable angina. So there should be reduction in the energy requirements in the morning, early morning, after a heavy meal, and the cold weather. The patient should be careful about it. Change in employment or residence may be necessary to use the physical activity. Isotonic exercise that is within the limits of the patient's threshold can be prescribed, okay, or can be advised. Now, one thing I want to mention here that regarding the adaptation or limitation of, we can use the results of treadmill test. Because in the treadmill test, we will subject the patient to external workload, so we can quantify the workload which will result stable angina in a particular patient. Patient can be prescribed or patient can be advised for activities which are below the threshold of the external workload which we can get from treadmill test. So treadmill test is important for diagnosis as well as for the treatment purpose also. Okay. Treatment of risk factors, again very important. We need to identify the risk factors. As I said, we need investigate the patient, find out what are the risk factors for the development of coronary artery disease. We need to treat those. So we need to treat obesity, need to treat hypertension. The patient should be asked to stop smoking. We need to treat We need to control the blood sugar level in a patient of diabetes mellitus, and we definitely control or treat the dyslipidemia. So these are the important risk factors which needs treatment. We want to reduce the future cardiac events in the patient of stable angina. In this lecture, I will not discuss about the treatment of these risk factors. I will discuss class. Drug therapy. Okay, what are the medications we use for treatment of anginal pain and of stable angina? We use nitrates, very important drug. Nitrates has to be used in a patient of stable angina until indicated. So what are the mechanism of action of? Sure, you have read this physiology class, but here I'm going to give you a quick vision and idea about the mechanism of action and how does it help a patient of stable angina. It causes systemic venodilatation. Because it causes systemic venodilatation, veno means dilates the veins. Since it causes systemic venodilatation, it reduces the preload for the heart. And since it reduces the preload, it reduces the myocardial wall tension and oxygen. Okay. And very importantly, it also dilates coronary vessels. So these are the mechanism of action of nitrate, which acts as a venodilators. It reduces the load, thereby reducing the oxygen demand of the heart, and it dilates the coronary vessel. So there are different preparations of nitrates which is available. We can use, okay, in the form of nitroglycerin. Nitroglycerin comes in forms like ointment, transdermal patch, sublingual tablet, and spray. Sublingual tablet to be used at a dose of 0.3 to 0.6 milligram, and it should usually be used for 3 times or 3 doses to be given 5 minutes apart. Up to 3 doses 5 minutes apart to be. Isosorbide dinitrate and isosorbide 5-mononitrate have only oral formulation. So isosorbide dinitrate oral formulation doses at 40 milligram 2 to 3 times daily can be given, and oral sustained release doses 120. Isosorbide 5-mononitrate oral dose is 20 milligram twice daily to be given, and sustained release the dose is 32 once daily. So this is about the nitrates. Different formulation of nitrate: nitroglycerin, isosorbide dinitrate, and isosorbide. Next, very important drug, beta blockers. It reduces heart rate. We already know that cardioselective beta blockers, the E1 receptor blocker, cardioselective beta blocker, they will reduce heart rate, they will reduce blood pressure, reduces arterial pressure, and they reduces cardiac contractility. Since they reduces heart rate and they reduces cardiac contractility, reduces the myocardial. This is how it helps a patient of stable angina or ischemic heart disease. So what are the beta blockers we have in our armamentarium? We have these beta blockers like acebutolol, etinolol, doxolol, bisoprolol, ismolol, ultra short acting. So just to tell you that, just to mention that, since it is an ultra short acting beta blocker, it can be used intravenously in those who have relative contraindication. So it is important to know. Labetalol actually it is both alpha and beta blocker. Usually it is used in hypertension. Metoprolol, nadolol, nebivolol, pindolol, propanolol, timolol. Among all these beta blockers, the most commonly used beta blockers are bisoprolol, metoprolol, nebivolol. Okay, these are the cardioselective beta blocker most commonly used for stable angina. So this is about beta blocker. The dose of bisoprolol is 10 milligram per day. Metoprolol, that is 50 to 200 milligram per day. Nebivolol, that is 5 to 40 milligram. About the beta blocker. The next group of agent is CCB, meaning calcium channel blocker. Again, one of the very important names. What is the mechanism of calcium channel blocker? The mechanism of action in a patient is almost same like beta blocker. It reduces heart rate, reduces arterial pressure, reduces myocardial contractility, thereby decreases the oxygen demand. Okay. So these are the calcium channel blockers available, okay, for clinical use in ischemic heart disease. They can be there can be dihydropyridine group of calcium channel blocker and non-dihydropyridine. So in the dihydropyridine group, we have age-old drug, that is amlodipine, felodipine, isradipine, nicardipine, nifedipine, okay, nizoldipine. These are the drugs in the group of dihydropyridine calcium channel. Non-dihydropyridine group, we have diltiazem and verapamil. Just to mention that diltiazem and verapamil, they have direct myocardial suppression. That is why they are not combined with beta block. So again, diltiazem and verapamil, that is non-dihydropyridine group of calcium, they should not be combined with direct myocardial suppression. Okay. For amlodipine, I will just talk about the common drugs. For amlodipine, the dose is 5 to 10 milligram per day. Okay. Nifedipine dose, immediate release 30 to 90 milligram, slow release 180 milligram. For diltiazem, immediate release 30 to 80 milligram 4 times daily, slow release 120 to 20 milligram. Verapamil, immediate release 80 to 160 milligram 3 times a day, slow release 120 to 40. The most common side effects, they are usually harmless, but the most common side effects of calcium channel blockers are headache, and they may cause pedal edema. These are two most common side effects of calcium channel. Now, I have said the anti-anginal drugs like nitrates, calcium channel blocker, and beta blocker can. Among the calcium channel blocker and beta blockers, which one to choose? Because both of them have almost similar mechanism of action. Now, we need to use beta blocker as initial therapy for angina. Why so? Because in studies it has been seen that beta blockers, they increases the life expectancy of patient of infarction, whereas calcium channel blocker, they do not increase the life expectancy. So if we have to choose between calcium channel blocker and beta blocker as an initial agent, we use beta blocker if there is no contraindication. But there are certain cases where we cannot use beta blockers. In those cases, we use calcium channel. For example, if there is contraindications to beta blockers, if there is contraindication to beta blockers, if there is intolerable side effect of beta blockers. So what are the common side effects of beta blockers? Depression, sexual dysfunction, fatigue. If this is tolerable, then we can beta blocker. We give calcium channel blocker to the patient. If I have to talk about few important contraindications, I would say beta blockers cannot be used in case of obstructive airway disease, in case of bronchial asthma, in cases of atrioventricular block, in peak sinus syndrome, in cases of peripheral vascular disease, Prince metal angina. These are the contraindications of using beta blocker. Chronic obstructive airway disease, bronchial asthma. These contraindications are very important. In cases we should not be using beta blockade because more harm than. Please know about the contraindications. AV block, atrioventricular heart block. Then in case of sick sinus syndrome, in cases of peripheral vascular disease. What peripheral vascular disease? In cases of Prinzmetal angina. Prinzmetal angina. These are some contraindications of beta. Not use beta blocker for contraindication. Use calcium channel blocker in those groups. And the other one is if there is intolerable side effects of blockers, like as I said, fatigue, sexual dysfunction, depression. Then we need to use calcium channel blocker in the particular patient. The next slide is about some common side effects and contraindications of benzene. For nitrates, the common side effects will be like headache, flushing, hypotension. These are certain common side effects: headache, flushing, hypotension, syncope because of postural hypotension, reflex tachycardia. These are some common side effects. They are usually tolerated, and it is advisable that nitrate should always be started under observation. Contraindication: hypertrophic cardiomyopathy. We give nitrate in a patient of hypertrophic cardiomyopathy. Beta blocker, I have already talked about the common side effects and the contraindication profile. Calcium channel blocker also, I have talked about the common side effects of blocker like they and then the peripheral pedal edema. Contraindication to calcium channel blocker are like cardiogenic shock, severe aortic stenosis, and obstructive cardiomyopathy. And we cannot use calcium channel blocker in a patient. So next, now I have talked about the anti-anginal agent, nitrate, beta blockers, and calcium channel. Now, a very important group of drug, that is antiplatelet. Among the antiplatelet, we use aspirin. Okay? The magic drug aspirin should be administered every day in a dose of 75 to 25 milligram per day. Okay? Aspirin, it is what does it do? It's an irreversible inhibitor. It is an irreversible inhibitor of platelet cyclooxygenase. Since it inhibits the platelet cyclooxygenase, it inhibits platelet activation. Okay? So aspirin should be used until it is contraindicated. Aspirin can be contraindicated, has gastrointestinal bleeding, active GI ulceration, or who has allergy to aspirin. In those cases, aspirin cannot be used. Clopidogrel is the other antiplatelet agent. It is a P2Y12 receptor inhibitor, okay, and it inhibits the aggregation of aspirin inhibits activation of platelet, clopidogrel inhibits aggregation of platelet. Clopidogrel should be used as a loading dose of 300 to 600 milligram, and then it can be followed by when we need to use clopidogrel. The combination of aspirin and clopidogrel, that is dual antiplatelet agent, to be used for 1 year after the patient has undergone coronary stenting. Okay, so that is the main indication of using this both antiplatelet agent, dual antiplatelet for a period of 1 year if the patient has undergone coronary stenting. Otherwise, in a patient of stable ischemic heart disease, there is no added benefit of using clopidogrel along with that. We have to remember. Prasugrel or ticagrelor. Prasugrel and ticagrelor are the other antiplatelet agents, Y12 receptor inhibitor. They are used in PCI patients. Okay, before the coronary stenting by percutaneous coronary intervention, these antiplatelet agents are usually, they do have a high risk of bleeding in comparison to other antiplatelet. Other drugs, if we talk about ACE inhibitors, okay, angiotensin convertase enzyme inhibitor. It is most beneficial in ischemic heart disease patients with diabetes mellitus or left ventricular dysfunction. If the patient does not have left ventricular dysfunction, or if they do not have diabetes mellitus, then probably ACE inhibition not give any added benefit. So we need to see that if the patient has diabetes mellitus or left ventricular ACE inhibition. Those who have also ACE inhibition should be used in those who have not achieved adequate control of blood pressure and LDL cholesterol on beta blockers. So these are the two major. Indications of using ACE inhibition, angiotensin convertase enzyme inhibition. The other drug is Granulasin. The other drug is Granulasin if symptomatic despite conventional therapy. Conventional therapy already I have discussed, anti-anginal therapy, that is beta blocker, calcium channel blocker and nitrate. Even after optimal dose of the conventional therapy of anti-anginal drugs, if the patient is not responding, then we can add this group of drugs, okay, the other group of drugs. One of them is Granulasin. If symptomatic after conventional therapy, we need to use. What does it do? It inhibits the late inward sodium current. Thereby, it limits the sodium overload of ischemic myocyte, and in turn, it reduces calcium overload. Okay? It has to be used in a dose of 500 to 1000 milligram twice daily. So Granulasin, it is a newer drug. It will inhibit the inward sodium current, late inward sodium current, and then it will limit the sodium overload of the myocyte, and because it limits sodium overload of the myocyte, will reduce the calcium overload as well. Okay, so this is how it helps in angina. One of the other newer drug, that is Nicorandil. How does Nicorandil help? Nicorandil is a potassium channel opener, and it also reduces the free intracellular calcium ions, and this way it helps the angina. So the dose is 20 milligram twice a day to be used. Ivabradine. Ivabradine is again one of the important anti-anginal drug. It inhibits SA node. Okay? But it has to be used if the patient's resting heart rate is 70 or more, okay, even after using a beta blocker. Okay? We need to use beta blocker first, and if the patient's resting heart rate remains more than 70, then we need to use the Ivabradine. Okay? And the patient should also have LV systolic dysfunction qualified for the use of Ivabradine. No benefit in those who do not have clinical heart failure. So the patient should have left ventricular dysfunction along with clinical signs of heart failure, and the resting heart rate should be more than 70 of beta blocker. So 2.5 to 7.5 milligram twice daily is the dosing. The last part, that is coronary revascularization. Okay, coronary revascularization indications are unstable phases of the disease, intractable symptoms, severe ischemia, high risk coronary anatomy, diabetes, and impaired LV function. Okay, these are the indications of coronary revascularization. So, the last part, that is management of the patient with ischemic heart disease, the protocol for the management. Initiate the medical therapy, as I have mentioned. There is decreased demand ischemia, minimize ischemic heart disease risk factors, I have mentioned, and use antiplatelet agents. If there is any high risk features like if there is low exercise capacity or ischemia at low workload, large area of ischemic myocardium, ejection fraction less than 40%, and acute coronary syndrome at the presentation. These are the high risk features. If there is no high risk features, we need to see if the exertional symptoms are controlled. If the symptoms are controlled, then continue medical therapy and assess the patient periodically. Okay. And if the symptoms are not controlled with the conventional medical therapy, and if the patient has high risk features, then refer the patient for coronary arteriography. Anatomy is suitable for revascularization? Yes, then we can go ahead with PCI, percutaneous coronary intervention, if it is a single vessel disease, or we can go ahead with either PCI or CABG if it is a left vessel disease or multi-vessel disease. And if anatomy is not suitable, then we need to consider for unconventional. Okay, so this is the protocol of managing a patient with ischemic. So this was all about stable angina and how do we manage a case of stable angina. So we will end here today. I hope this class was helpful for you. Thank you so much. Please share the video and follow the upcoming. Hi everyone. I can see there are so many messages in the live chat. Good evening everyone. Good evening Sama, Gokul, Rebi, Mohammed Reis, then Yash Kumar, Vivek, lovely nursing students, Rahul. Good evening everybody. If you have any queries, you can ask me in the chat box. If you want to know anything, if you have any queries, you can ask me now. Here to clear your doubts. Please ask if you have any queries or any question regarding today's topic. I will clear the doubts. Thank you so much. As there is no query, I hope thank you, Ajita. Thank you so much. Please follow the upcoming classes. I hope it will be beneficial. Hiru, do you have any question? If you have any questions, you ask me if I'm there. Yes, I'm there. If you have any query or question, can please ask me. Hiru. Thank you for all the appreciation, everyone. Uh, Abhinandan. I can see. Okay, it is deleted. Mr. Abhinandan Bhattacharya was saying something. Anyway, Abhinandan, if you want to ask anything here.